Assalamu alaikum. Good day to all of you, dear doctors. Today I am going to share a brief discussion about shoulder joint, which is very important for MRCS part and part examination. Here's the shoulder joint, which is a shallow synovial ball and socket type of joint, and it is an inherently unstable joint, but it is capable to a wide range of movement, and its stability is provided by muscles of the rotator cuff that pass from the scapula to insert it into the greater tuberosity of the humerus, and all of these are inserted into the greater tuberosity except subscapularis, which is inserted into the lesser tuberosity. Okay, then glenoid labrum, which is fibrocartilaginous rim attached to the free edge of the glenoid cavity, and here's tendon of the long head of biceps arise from within the joint from the supraglenoid tubercle and is fused at this point to the labrum. Here's the tendon of long head of biceps. Here's long head of biceps. It is the tendon of long head of biceps arise from within the joint from the supraglenoid tubercle and is fused at this point to the labrum, and the long head of triceps attached to the infraglenoid tubercle. Here's the long head of triceps, which is attached to the infraglenoid tubercle, and fibrous capsule Here's the fibrous capsule, which is attached to the scapula external to the glenoid labrum and to the labrum itself posterior superiorly, and which is attached to the humerus at the level of anatomical neck of the anatomical neck superiorly and the surgical neck inferiorly. Anteriorly, the capsule is in contact with the tendon of the subscapularis, superiorly with the supraspinatus tendon, and posteriorly with the tendons of infraspinatus and teres minor. All these blend with the capsule towards their insertion. Two defects in the fibrous capsule: superiorly for the tendon of biceps, anteriorly there is a defect beneath the subscapularis tendon. The inferior extension of the capsule is closely related to the axillary nerve at the surgical neck, and this nerve is at risk in anterior-inferior dislocations. It also means that proximally sited osteomyelitis may progress to septic arthritis. And movements and muscles involved in shoulder joints are here: flexion, extension, adduction, abduction, and medial lateral rotation. In flexion, the muscles anterior part of deltoid. That's the anterior part of deltoid. Deltoid muscle and pectoralis major pectoralis major and biceps and coracobrachialis, which are involved in flexion, and in extensor posterior deltoid such as this one, and teres major and latissimus dorsi. That's the teres major and that's the latissimus dorsi. All of these are involved in extension, and in adduction here's involved pectoralis majors are involved in adductions, and latissimus dorsi is involved in adduction, and another one is teres major, and the last one is coracobrachialis. Okay, and in case of abduction, muscles involves medial mid deltoid and supraspinatus is the muscle of the rotator cuff, one of the muscle of rotator cuff. Supraspinatus or supraspinatus. This one is supraspinatus, and in case of medial rotations, there's involved anterior deltoid, subscapularis, and teres major and latissimus dorsi. And in case of lateral rotations, posterior deltoid. In case of lateral rotations, and involved muscles are posterior deltoid and infraspinatus, which one is this one is infraspinatus, and another one is teres major. This one is teres major, and these are involved in lateral rotations. Here's the important notice about shoulder joint abduction is the first 0 to 15 degrees of abduction is produced by supraspinatus. First 0 to 15 degrees of abduction is produced by the supraspinatus, and this is supplied by nerve, suprascapular nerve, and the middle fibers of deltoid are responsible for the next 15 to 19 degrees of abduction, which is this one is middle fibers of deltoid, which is responsible for the next 15 to 19 degrees of abduction, and this middle deltoid is supplied by axillary nerve. And above 90 degrees, the scapula needs to be rotated to achieve abduction, that is carried out by the trapezius, which is supplied by accessory nerve, and serratus anterior, which is supplied by long thoracic nerve. This one is trapezius, and it maintains above 90 degree abductions, and another one is serratus anterior, which is supplied by long thoracic nerve. Now the muscles of shoulder joint abduction. Step 1. Abduction of the shoulder joint is initiated by the supraspinatus muscle. Range of motion here at glenohumeral joint 0 to 15 degrees and 15 to 90 degrees are involved in deltoid muscle, the major abductor, and abducts to 90 up to 90 degree, and the above 90 degree involves trapezius and serratus anterior muscles. Rotates the scapula upwards. Range of motion at glenohumeral joints 90 to 180 degree. Here's the important anatomical relations of anatomical relations in shoulder joints includes the anteriorly brachial plexus. Here's the anteriorly brachial plexus and axillary artery and vein, and posteriorly has the arteries of axillary artery and veins, and posteriorly suprascapular nerve and suprascapular vessels, and inferiorly axillary nerve and circumflex humeral vessels. Okay, here's all about shoulder joints. Now I think all about in shoulder joints are clear to all of you. If any questions, just comments in our Facebook group or WhatsApp group or Telegram group. Thank you so much.